Next, we've got Renée Roux, a medical oncologist based in Oxford, who specialises in systemic treatments for breast and ovarian cancer. She completed her research in the Institute of Cancer Research and is the systemic anti-cancer treatment chair and operational lead at the OUH Trust, Gynae subspecialty research lead for the Thames Valley Research Network. She's got a lot of other letters in here, but she's come to talk to us today, particularly about high-grade serous. One of the comments that sometimes I get back about this meeting is that we sometimes cover some topics that are considered more the realms of our subspecialist colleagues. But I do think this is an important one to cover, particularly as a lot of our women with advanced ovarian cancer are presenting through A&E, and as units and often working in diagnostics, these are the people that we're seeing quite often. So thanks, Renée.
Thank you very much for the kind introduction, Amy, and thank you for the opportunity to, as a medical oncologist, to be speaking largely to surgeons and people in units. And I think, as Amy says, it does just reflect the heterogeneity of what we're all doing. So those are just my disclosures. And Amy wanted to talk about high-grade serous, and I guess it's the obvious one. There are other types of ovarian cancer that we treat, but by far the vast majority are high-grade serous. It's the most common subtype, and they, from an oncological perspective, are at least chemosensitive, or at least initially. So, when looking as a medical oncologist and looking at what's new, which is part of the topic of this, of course I'm going to spend the whole talk doing a deep dive into all the horizon scanning of everything that is coming up in what's new for ovarian cancer. So, antibody-drug conjugates, there are vaccine studies, oncolytic virus therapies, engineered cytokines, immunotherapy, to name a few. But you'll be very pleased, I'm not going to be doing that. Amy, when I asked her what people might want to hear about, she said, not too many trials. So I'll try and change that. So going to talk a few things, but about maintenance, just looking at ovarian cancer's natural history, and just sort of flavored things. What she did say was maybe talk a bit more about BRCA, possibly about immunotherapy, who gets it, who doesn't get it. And then, because I couldn't resist, we'll briefly discuss one trial that published earlier this year, and that's a TRUST trial, but it's a surgical trial. So in terms of BRCA, I think we're very fortunate in the UK. Most centres have set up. The BRCA story is not new. We've been looking at more personalised medicine and oncology for a number of years, and we've got very good treatments for patients with BRCA, or what we used to call BRCA-NES, which is now most likely homologous repair deficiency. And we've been very fortunate, but there are still barriers to getting. Not every centre or unit has access to easy BRCA testing. It does require more time in clinic. It does require counselling. And then getting tissue off for homologous repair testing is, there are still barriers to that. So if we just very briefly summarise, BRCA1 mutations have about a 40 to 50% cumulative lifetime risk of developing ovarian cancer. BRCA2 is less so, around 20 or 25%, but that's still much higher than the prevalence in the general population for ovarian cancer, which is around 2%. So we get two different types of testing and two different mutations that we're looking out for. Firstly, there's germline 2 mutations, and these are inherited from a biological parent. So every copy of that gene in every cell will be altered. So that accounts for about 15% of patients with ovarian cancer, and then usually high-grade serous. And then we also, more recently, we also look at actually somatic testing, which is not inherited, and these could occur in the DNA at some point after birth. And so this involves sending tumor samples off. And this is, I think, and that affects about 7% of patients. So overall, just over a fifth of patients will have one of these mutations, and reason why, important to check for that because of the treatments we're able to offer. So tumor testing, again, as mentioned, involves counselling. It requires the actual germline testing is fairly straightforward. Quite a few centres or units have nurses who take on that role. We don't have that in clinic. Our CNSs are too busy, so it still comes into an oncology clinic for that, but it is becoming more and more routine at diagnosis. First time we see them, we also discuss BRCA testing. Then we ask patients, and we just need verbal consent for them, can we send off their tumor, their biopsy sample for somatic testing? And this is actually quite an involved process, and we always, sometimes it takes 3 months for these results to come back. They get sent off. Our local genomic hub is in Birmingham, and so there's quite a few. Firstly, pathology have to choose which slides to send because they need to be able to extract. They need to be having slides where there's high nucleic acid content so they can extract DNA, because there's nothing more frustrating than waiting 3 months for a result and it comes back as a failed due to not enough quality DNA. So, and then once it goes to the lab, there's they do their own pathology reviews, they extract the DNA, the various preparations, and then next generation sequencing takes place, and we eventually get sent a report about their status, which is a genomic instability score. And based on certain criteria and according to the Cancer Drug Fund, what levels we can give which drugs for these patients. So is it important to know about BRCA? Of course it is for patients. I mean, we know that patients who are diagnosed with a BRCA mutation prior to a diagnosis of cancer, which is the ultimate goal, doesn't happen very often. Unfortunately, it's mostly patients being tested once they've had a ovarian cancer or other cancer diagnosis. But there's a lot that can be done in terms of counseling, prophylactic surgery if need be, and a lot of you will be asked to do prophylactic BSOs for these patients, particularly breast cancer patients diagnosed with a BRCA mutation rather than the ovarians who will be having surgery anyway. And so I think in terms of the importance and outcome for patients, they tend to be high-grade and very advanced ovarian cancers. You can benefit from longer treatment-free intervals, and actually, it's not all bad news. A lot of BRCA patients do far better than sort of non-BRCA patients. And it also brings just very quickly to the role of PARP inhibitors, which I think in medical oncology, we're now sort of so past them. We've had them available since just before 2020, outside trial and licensed. And, it's almost like old news for us. And we're always wanting to move on to the next thing. But actually, these drugs really have revolutionized the landscape, particularly in first-line and maintenance settings and for BRCA mutated patients. So PARP inhibitors basically prevent DNA damage repair so the cancer cell dies. We usually start them within 8 to 12 weeks after completing chemotherapy, and we've got 3 drugs available to us, and they are all in tablet form, and patients can be on these for anywhere between 2 and 3 years, sometimes longer, depending on the circumstances. Everything is through the Cancer Drug Fund, and a lot of the timing and eligibility and the choice of which sequence and combination we use depends on their BRCA status. So, in summary, if you've got a BRCA mutation, olaparib as a drug is probably sufficient. Non-BRCA, but HR deficient on tumor testing, which is where that comes in, you can use a combination with something like bevacizumab or Avastin. And if you're non-BRCA, but still HRP, which is proficient, which is about 80% of our patients, usually just on bevacizumab, and then we keep a PARP for future use, just so we've got something in subsequent lines. The other question Amy wondered about was immunotherapy, and I've got a courtesy of a colleague of mine, Dr. Nykim, London, for some of these slides. Is there a role for immunotherapy in ovarian cancer? We've been asking this for about, 5 years. And, again, immunotherapy have been revolutionary in drugs, not just melanoma anymore, but in certain lung cancers, uroepithelial cancers, and in certain breast cancers, and many of you will know at the moment in terms of gynecological cancers, ovarian cancer was always the gynae cancer that had the most treatment options, poor prognosis, but many therapeutic chemo options, and advanced endometrial cancers or advanced cervical cancers really very limited in terms of options. So immunotherapy for those tumor types, endometrial, most of the benefit in MMR deficient, but increasingly this year NICE and have approved the use of pembrolizumab and durvalumab in patients with even MMR proficient disease. So this has been a real game changer in endometrial cancer and also to an extent in cervical cancer as well, with far better outcomes. Ovarian cancer, not quite so much. So looking at the sort of objective response rates, really quite poor. And this is with what everyone wanting to jump on the immunocheckpoint bandwagon. And patients, we tried nivolumab, we tried every type of immune checkpoint inhibitor out there in the first line setting, and generally very, very limited single agent activity. But, oncologists are never quite happy to leave it there and just say, it doesn't work. We're going to try, and if we don't try and fail, we're going to try with a different combination. What about adding in another drug to the immunocheckpoints? And so comes in bevacizumab. And again, you'll see here, these are all first-line studies. This is platinum sensitive, and this is platinum resistant. So these tend to be the lines. Everything in this reddy pink is negative. This year at ESMO, 3 studies got presented in that first-line setting because chemo, immunotherapy, and beva wasn't enough. Oh, no. We had to then add in a PARP inhibitor in addition to that. So positive studies to an extent, but actually, really, we've sort of mulled over this data quite a lot. Not convinced. It's still no overall survival benefit, bit of progression-free survival, but with significant additional toxicity, as you can imagine, in these patients with now expected to undergo combinations of 3 or more drugs at a time. Out of the blue, and we'll watch this space, is in the platinum-resistant setting. There was one study with weekly Taxol suggesting maybe a benefit for single-agent pembrolizumab. We're not quite sure why. Is it an outlier? Is it something to do with the weekly Taxol effect? Not quite sure. So is it practice changing? Probably not yet, because it's with bevacizumab. We can't use it in that setting anyway due to Cancer Drug Fund rules. So I'd say so the story in ovarian cancer is, I think, still a resounding no in terms of immunotherapy. They're not the right group of patients. I would just add one caveat to that, though. ClearCell sort of ran the Peacock-style trial recently, and that did show for ClearCell 30% objective response rates to immunotherapy. So watch that space, and that's slightly more niche group. Right, I'm going to just very mention, I know you probably think that what does a medical oncologist have has no business talking about a surgical trial to a group of surgeons, so, or mostly surgeons. And I think, it's not just oncologists who, if at first you don't succeed, you try again. I think gynae-onc can be accused to a similar extent, in the same way. The TRUST trial, why? So many studies, the age-old debate in MDT about neoadjuvant chemotherapy and then interval cytoreductive surgery versus primary cytoreductive surgery. Every study to date, negative. I think there was a lot of discussion after the CHORUS trial, which is quite a while ago now, but I think probably many in this room would still be familiar with and recruited into that CHORUS trial, which was the UK study. Very disappointing results. I mean, no surprises, no difference between neoadjuvant versus primary treatment, but there was a lot of criticism up and down the country about, well, it depended on the surgical expertise, the volume of these sort of complex cases coming through the centres, and the sort of the thought, and I don't know, maybe slightly arrogant thought, I don't know, maybe that's the wrong way to quite phrase it, but maybe the thought was, well, maybe in the right hands, this could be achieved. So, TRUST trial. So the basic design was patients with an epithelial or tubo-ovarian cancer, FIGO stage 3B or C was the lowest, and could include stage 4A and B as well. And patients had to obviously be fit enough to tolerate treatment, and they were randomized in 1-to-1, quite a large number of patients, just under 800, to either receiving primary cytoreductive surgery or neoadjuvant chemotherapy followed by interval cytoreductive surgery. And I'll come back to this, but the primary endpoint, overall survival. So looking at the patient characteristics, I think just a couple of things to point out. Most of, nearly 30% of patients were actually stage 4A or 4B, and this is where it always gets interesting in our MDTs, because we discuss, If it's resectable, sure, but what about the biology of the disease? This is a chemosensitive disease. What are we doing? Stage 4AB, these patients have very poor, long-term survival, less than 5%. Is this really the right role? But this study did include quite a large number of patients with stage 4 disease. And then the other thing to say, again, because it's a high-grade serous, no surprises, the vast majority of patients, over 90%, were high-grade serous. So if we look at the results then, looking at the bottom here, complete resection, so patients who'd undergone primary cytoreductive surgery, 70% achieved R0, which is, of course, the gold standard, and then patients who'd undergone neoadjuvant chemotherapy first, followed by surgery, higher rates of complete resection, around 85%. Just a few things to point up and out in that, just because it's quite a busy slide, but wrong one. Here. So splenectomy, 27% of patients undergoing splenectomy. If you'd had neoadjuvant chemotherapy, that rate was much lower, 13%. And I think then stoma formation is another one to point out. In primary surgery, 20% stoma formation versus 8% after neoadjuvant chemotherapy. And one of the things when you're counseling patients for this sort of surgery, one of the things mostly, sort of more middle-aged ladies, one of the things they really, really dread most is a stoma. And this in the study was, either temporary or permanent. And in my experience, it's very seldom when patients are going through this, they still relapse after 18 months or so. And it's very seldom we get to a point where they do have their stomas reversed, although I think that trend is trying to change a little. So let's look at the results. Progression-free survival. Again, this was considered significant. Hazard ratio at 0.8, not overly impressive, but still there's sort of 19.7 months versus 22 months, which doesn't sound like a lot, but I think interestingly the trend is these curves here aren't coming together. So I think you can see that sort of progression-free survival actually, in fairness, is probably maintained. But then we go to the overall survival, and probably no great surprise, no overall survival benefit for this. But again, I would point out that although this come together, the lines don't actually cross. So too early to tell if there's any significant. There's a trend towards benefit, but again, no overall survival benefit. So despite maximal surgery considered, where there was only one centre in the UK that was entered into the study, and probably no surprises, this was the Hammersmith, and everywhere else was in Europe. And, again, I'm hoping that this will start to end discussions about this. So ovarian cancer, and one of the sort of maybe sort of interesting or slightly confusing things about the study is using overall survival as a primary endpoint in ovarian cancer, I think is ambitious and almost setting up to fail. It's a very difficult endpoint to reach because so much happens on a patient's journey from the time of developing symptoms. This is the primary intervention here, whether it be chemo, surgery, then followed by interval cytoreductive surgery. And then after that, patients go on to maintenance therapies, whole choice for that. They relapse, they go into further chemo, possibly another maintenance therapy. Somewhere in that 5% of patients undergo secondary surgery, and so on and so on. So to really try and look at that outcome in terms of overall survival when the landscape changes so much during that journey, I think is difficult. But I think on a more positive note, ending for this, good surgery, whenever possible, is good for patients. And I think that's the real key take-home and what we want for our patients when we discuss these cases in MDTs. So looking at, this was the CHORUS trial, but looking back now at what they call maximal cytoreductive surgery, these are looking, the CGR, that's an American slide, unfortunately, but basically that's talking about R0. And you can see that with that, the PFS does go up significantly. Does it really matter that much, whether it's upfront versus interval? Probably not. and I don't think we'd be sort of rushing to discuss it as intensely as we previously have in MDT. I think there's certainly a role for upfront surgery in patients. They're right patients, young, fit, highly selected patients, but otherwise, as long as they are getting good surgery at some point, that probably is enough. And that is me. Thank you very much.
Great talk. Thank you. Could you want to? You've run away.
Oh, sorry.
There may well be some questions.
Thank you very much for that. As unit leads, we tend to come across high-grade serous cancers quite often in the recurrent setting. For patients who recur with a primary high-grade serous cancer, who are outside of desktop 3 and won't be suitable for secondary cytoreduction, and were previously having tumors that were platinum sensitive, well, at the time platinum sensitive, and didn't receive PARP because it wasn't a thing then. Is there a role in that setting? So not suitable for secondary cytoreduction, getting rechallenge chemotherapy, and then not getting surgery and getting PARP?
Yes, there's certainly a role for that. So, cytoreductive, we looked at the desktop, if you look at desktop 3 trials, etc. So, the criteria are quite strict for secondary surgery. So very few patients get to that. And we always know that scans actually underappreciate what you're seeing. So it looks like you might only have a few sites. If people then have a diagnostic lap, then it's too much. And even if you did have surgery, you'd have to consolidate with sort of second adjuvant chemotherapy anyway. So in a very select few, that does go. If you've not used a PARP in the first-line setting already, yes, that certainly would be a very good option. And I think that's always our point, is that this is very much a systemic disease. Even if it's if it's from the fallopian tube, even if it's sitting on the ovary, that is already a metastatic deposit. We are almost always dealing with metastatic disease that can be very well treated systemically, at least initially.
Hi. Thanks for that. It's very useful, even for me in the cancer unit. One of the things I find really frustrating in working in cancer is the amount of imaging patients have to go through on their journey. So you start off with somebody who might have been a large number of ovarian cancers are admitted as emergency. They get suboptimal imaging when they're there. You go to take the MDT. You've tried and taken biopsies, ascites, drain refusions and everything. So, yes, okay, but it was 6 weeks since their imaging. They've been sitting on a medical ward. Let's repeat the CT scan and rediscuss it. You then try and get your CT scan, which then takes 3 weeks in a hospital because you're competing with every other specialty going. And then you get a delay, and they say, yes, right, well, they're not suitable for upfront surgery now. We'd better have interval debulking surgery. And then you then have more imaging, and then they say, you then have to discuss an MDT again. And then on the way you find out, oh, right, well, they've got a pulmonary embolus now. Oh, I've gone into obstruction and everything. And it's just so frustrating, the number of imaging times and the amount of delays, I think, which it results in making a decision for patients as to what treatment they should have.
I hear that, and sort of sitting and NDTs that become longer and longer and more complex, and a lot of them, and then from outside the unit, and then saying, oh, well, the scans haven't come across and therefore delayed by another week. I know everybody feels that huge sense of frustration. I think most of the imaging we do is in that diagnostic setup, certainly for ovarian cancer. We then only base subsequent imaging on follow-up if patients have previously had a baseline raised CA-125, and then we use that to track, and only if that's going up or patients develop symptoms do we scan, so initiate scans. But I think getting the right treatment initially is quite important, and we know high-grade serous is very aggressive, and it progresses really quickly, and what was okay 6 weeks ago in terms of that you don't want to miss the window either way, or be offering extensive surgery when it's not going to be an R0 resection. So I think it matters, but I think we all share that frustration.
It's your point about having a high-quality surgeon doing the surgery as soon as possible.
And then, in our trust, it's pre-op. That seems to be another. There seem to be so many additional factors into that, and theatre space, it is tricky.
Do you think now more and more centres are doing HIPEC, and at the moment at least HIPEC tend to be reserved for the interval setting. Do you think there's going to be a kind of a bit of a move away from primary surgery in order to give them HIPEC, or do you think we're just going to keep doing the trials with HIPEC until we can eventually find some small difference in the primary setting, just so we can do primary surgery?
Interesting question, and probably I'm hoping people like Tom Ince might be able to answer that better. I think in terms of we would love a HIPEC centre, we don't have one, so don't have that option. But pushing for one, which I'm not sure is going to materialise, I think there's certainly a role for HIPEC, which has certainly shown some benefit, but I don't think that's going to change rapidly. But I don't know if we need many more trials to do that.
That's great. Thank you very much.
All right, thank you.